First, thank you. I'm Jack Balghetti, and I'm a liver surgeon on transplantation. I'm far from diabetes. Also, during the last years, I saw more and more patients with chronic liver disease, with diabetes, and some patients with tumors due to MODY. And I was just nominated last year on the HAS board member, and probably because I'm a surgeon, I am responsible on the device. And I will speak about the HAS, which is the Haute Autorité de Santé. First, I can say that when I started, NICE was a model. Where is Adler? Yeah, NICE was a model, and every day I heard about NICE, and I saw what you present, that there are many, many similarities on the assessment, except that in France, the economic is not a priority, is not always put in France. So just I'll tell you that the French National Authority is an independent authority. They are absolutely not there. We have our own budget, and we have nothing to say to any other ministers or the government. We are independent, nominated for 6 years, and by the president, and then we can do as we want. And the aim is to improve the quality and safety of healthcare, to product guidance for healthcare practitioners, to certify healthcare organizations and healthcare practitioners, to inform practitioners, patients, and general public, and to advise about decision makers or reimbursement of pricing of health technology, products, and procedure. There are many similarities on that. What about the medical device? And of course, I will speak about general the medical device, and Guillaume will speak about the diabetic devices. After granting of CE marks, then we can assess the device. I will show you how we assess. And when we assess, we say that this device can be reimbursed. Then it's go back to the Minister of the Santé, the ministry, where the price is negotiated. We don't speak about the price. The price is never taken into account when we assess the device. That's for that means the ANSM is with the agents of security it has no role on this assessment. The role of this agency, the other agency, is authorization for the first use in man, the material vigilance, which is very important, regulation of market, and regulation of advertising. What is quite difficult to understand is that when we have to face to an assessment of a device, there are two types of inscription of reimbursable device. There is the generic line where they can have a direct access with the CE mark, and after initial definition of the HAS to say that they have common characteristic that speak technical specification, common function, and common indication. This set of products are reimbursed by health insurance in a single tariff. And the dossier has not to be submitted to HAS, but we have to reevaluate all the generic lines every year. And the tendency now is to probably reduce this generic line and to try to reevaluate. But it's a lot of work because now we have there are many generic lines, and we have to reevaluate all. What is the most is the brand. The second type of inscription is the brand name. And if the device doesn't meet the criteria of existing general lines, if there is a plus over an existing general line and innovation necessitating a specific monitoring, then it has been submitted to to HAs. And then that's where I work now. We have to answer to two questions. The first question, should the medical device be reimbursed? And then we take in account exactly like the NICE procedure, I think, except that our meeting is not public. That's, I think I noticed this is very important. We look on the literature, on recommendation, expert opinion. We have many difficulties on expert opinion because, for example, for diabetic, it's very difficult to have independence or opinion. And then we decide reimbursement or no reimbursement. And there is no reimbursement if the actual benefit is considered as insufficient. The second question, if it's considered as sufficient, then we have to graduate the clinical added value, and we have to give to say if there is an improvement in comparison with the medical care from 1 to 5. If we say that there is no medical improvement, it is level 5, the consequence is very important because the price will be the price by the Ministry of Health. The price will be quite similar to the generic line. Second point, then after you understand now that we assess the benefit, the level of benefit, then there is the negotiation on the price with the Minister of Health. And then we have to say if we need some post-listing study, because each device will be reassessed, the mandatory, every 4 years. And there are some post-listing studies, and if we look to the criteria of this post-listing study, I must say, and I must confess, that this is probably the major change we have to, the impact we have to, the major things that we have to change in the future, because the post-listing is say that when we have we need further clinical data, we need a real condition of use if we have uncertainty, we need, so it means that it's not regular, it's not mandatory, and I think that this point is very important. And now I want to give the word to clinical about Guillaume.
Thank you, Jacques. So I am Dr. Charpentier. I am a pure diabetologist clinician, and I work in the Centre Hospitalier Sud Francilien, which is a big reference hospital for the whole south suburb of Paris. In France, for very specific diseases that need device and treatment at home, for example, oxygen therapy for some chronic respiratory disease or enteral nutrition for cancer or health, there is a specific system which is called LPPR, Liste des produits et prestations remboursables, which take care of that very specific treatment. Before the year 2000, the pump therapy were included in the global budget of hospital. As you know, there was a lot of big shortage of money in hospital at that time. So at that time, it was really impossible to have some treatment with pump therapy, and very few patients in France could benefit of this treatment. In 2000, thanks to the pressure of French Diabetic Association, this treatment was moved from the hospital to the LPPR with some advantage, as you can see. From that time, of course, this treatment is fully reimbursed, and patients can have unlimited access if, of course, there is a medical prescription, and if they have diabetes, that cannot be satisfactorily controlled with multiple subcutaneous insulin injections. They have also, this treatment should be also initiated in a hospital initiation center on a short hospitalization, and there is some characteristic of that initiation center, very simple. Of course, they need to have a multidisciplinary team specialized in diabetes and some requests as training and 24-hour, 24 availability for emergency and so on. And since that years, there is a service provider, usually a private structure that operate under the LPPR condition, and since 2000, patients have such service providers that provide them pump and all tubing, free of charge, of course, come within the hospital to train them from a technical point of view, not a diabetic point of view, but technical point of view, how to operate their pump, assume a good technical maintenance, also material vigilance, and there's a question mark, I will talk a bit about that after. And also the service provider has to follow the patients at home each 6 months to check that everything is under control from a technical point of view, and also to continue the technical training of the patient. But they are not allowed to go on with the treatment itself and, for example, to help the patients to adapt their insulin dosage, as you can see. But nevertheless, thanks to the LPPR system, now roughly 25% of type 1 patients could be treated in France with insulin pump therapy. But there is some obstacle to the use of complex device, and insulin pump is a good example. In fact, such a treatment need the follow-up of a specialist. It is not easy for GPs to manage that. And the problem is that there is a shortage of specialists in diabetes in France, as you can see, and there is many regions where there is very few or even no diabetes specialists settled, as you can see in the yellow or white area here. And this medical demography will not improve and continue to decline up to 2020. So this is a problem for that. And there was, to face this problem, there was a new law that has been settled 2 years ago, allowing some delegation from diabetologists, from Diabetologic Act by the diabetologists to specialized nurses. This could be seem very odd from UK and US because you used to have such a nurse since a long time, but in our country, nurses are not allowed to prescribe or to modify any treatment outside the hospital. It is like that. But thanks to the HPST law, now it is allowed, but in a very specific condition. We have to create a national protocol for any specific situation, and this process could take 1 or 2 years. And after that, there should be an implementation on a regional basis and have the allowance of regional authorities. That means many headaches with many papers, but also another thing is that care that could be done by nurses at that time is not paid. There's also some post-marketing survey problem, as you know, because the culture of French doctors, this is not very well an habit, and the communication of problem is not well done. And also from the service provider, in the LPPR, service providers have operationally a very good attention for that, because as far as there is any problem with the pump, the providers return the pump with problem to the manufacturer that give him back immediately a new one. And roughly 25% of the pump are returned by the provider to the manufacturer each year. This is from an operational point of view, but from an administrative point of view, the declaration to the ANSM, I'm not so sure it is very efficient and nor exhaustive. So about this shortage of specialists, telemedicine could improve this problem, and diabetes type 1 is a good example because we have in France the DIABELOOP system, which is an active telemedicine system with automated remote management of insulin dosage, plus telemonitoring by specialized nurse under the responsibility of diabetologists. But this system, which is not a device but more or less a service, doesn't fit with any generic line of the LPPR or anything else. So at that time, it is very difficult to get the way to be reimbursed for just a treatment, which is an association of software, operational remote system with specialist nurse, and diabetologists in second line. So at that time, it will probably take many years to have a generic line which could be written in the funding system. Another obstacle to settle telemedicine in France is there is a regulatory framework that need to have implement such a telemedicine on a regional basis, and we have to get the authorization from the 22 regional health authorities. That is another headache you can imagine. As you understand, it could take many years to write a new line in the funding system, and for that we have to imagine and to be in advance for the next breakthrough technology innovation in the field of diabetes. That could be the artificial pancreas, which is of course a composite system with several software, with patch pump, with CGM, which could be other device, and also, of course, not only a device, but also a very effective telemonitoring, safety, continuous analysis, and that could allow the intervention at any time of healthcare provider specialized in that system. So this is the next future we have to discontinue up now thanks to the inertia of the system. But I have heard that there could be some innovation in innovations. Yes. Maybe Jack can tell us.
Yes, in France, within few hours, maybe within a few days, a new decree will be published on in order to give provisional reimbursement for innovation. We will take a risk. I am responsible of a jury, and we accept to take a risk. If there is an innovator rupture, I mean not increment, if he has a CE mark, no official's financial support, here there are some arguments in favor of beneficial clinical or economic improvement, no argument for specific risk, and insufficient data for regular judgment. This jury, similar to an editorial board of a big journal, would decide within 1 month if it's an innovation, if it's innovative, and if the study, because we do not want to just reimburse and to see, we reimburse with a study, with a controlled study, and if the study will be able to establish the benefit of the procedure. And then we have the French authority will reimburse during this period from 3 to 5 years the device and the financials, and give a financial support for the study. This is what we are starting today. Thank you for your attention.